moved around. Okay, I'd like to introduce Dr. Lianne Hirano. She completed her fellowship in geriatric medicine at the University of Washington. She is board certified in internal medicine, geriatric medicine, and hospice and palliative medicine, and she continues to care for patients and teach as an attending and associate medical director for palliative care at Harborview Medical Center in Seattle. She's also program director for the hospice and palliative medicine fellowships at UW. She's worked in a number of care settings, including skilled nursing facilities, long-term care facilities, outpatient palliative care clinic, and was a director at Providence Hospice of Seattle. Through her experience working with families at Harborview and out in the community, she's had the privilege of interacting with many patients and caregivers and has some wonderful information and insights to share with us about end-of-life care and dementia.
Thank you, Barb. It is always such a privilege to be here and do one of these presentations with all of you. And I'm hoping for some lively discussion in the chat at the end. I have a lot to kind of go through because I think I could spend all day, at least several hours, talking about end-of-life care in dementia, which I think is actually quite important and something that a lot of people don't completely recognize when they see it actually or have heard about. So I'm so glad you're here with us today to learn a little bit more about end-of-life care in dementia. So there we go. Okay, so what I'm hoping to cover today is definitely definitions. What is advanced dementia actually? What does it look like? What does the disease progression look like? I know you're going to get so much on dementia from the wonderful Dr. Stephen Thielke, who I always appreciate and enjoy learning about dementia from as well. And so I'm really going to focus in on the end stages of dementia and advanced dementia. And what I'm going to focus in on particularly is advanced dementia almost in isolation, in the sense that I know that there's a lot of folks who have dementia who end up dying from other comorbidities or other illnesses like heart disease or stroke or infection from other conditions that they might have. And then there's a group of folks who are relatively healthy and robust with the exception of their dementia illness. And so the folks I'm going to focus on are going to be the ones who actually are going to die from dementia itself, as opposed to those who have dementia who might have more milder stages and have other comorbidities that they're at risk for mortality from. So clinical picture, again, disease progression, which will cover 2 of my 4 M's, mentation and mobility. And then I want to get into some treatment and care. So that'll help us all with thinking through anticipatory guidance, those guideposts in the disease process itself, when to think about when to have these conversations or bring up certain guideposts for anticipatory guidance for your patients and families. And then tools to achieve treatment or care aligned with patients or proxies, values and goals. So this will get into medications, which I'll touch on briefly, and then what matters most, right? Which is kind of at the meat and heart of what I do a lot of in palliative care. And at the latter half as well, I'm going to get into palliative care and hospice and when to think about or recommend. And most of this presentation will focus on what kind of language to use when you're introducing these ideas or topics or having discussions with your patients or their loved ones. And then at the end, as Barb mentioned, I hope we can get into some cases just to get the juices flowing and thinking through how to actually use some of this language and these tools in practice. Great. So as far as definitions, like I mentioned, dementia is a broad term for diseases of the brain that affect thinking, behavior, and memory. So I'm not going to focus in on one type of dementia specifically. In advanced dementia, in really the advanced end stages of this of a number of dementing illnesses, it starts to look similar as far as some of the situations or conditions that you might find as challenges near the end of life. So the types of dementia that kind of fall under this umbrella of advanced dementia that we will be talking about could be definitely mixed dementia, Alzheimer's dementia, vascular dementia, Parkinson's, Lewy body, frontotemporal. And I took this graphic from the Alzheimer's Association, which is a wealth of information, but I really like the visual representation of the umbrella because really it's true that these dementias kind of fall under the umbrella of dementia, but there are specific types of dementia, though as I mentioned at the end of life, they all start presenting with very similar challenges. Okay. So, is dementia a terminal illness? And believe it or not, this actually used to be a question about 15, 20 years ago. It was not something that was generally accepted as a terminal condition. So you might run into people, and maybe you yourself are not necessarily convinced that dementia is a terminal illness. So one of the landmark papers that did kind of define dementia as a terminal illness or confirm dementia as a terminal illness came from Dr. Susan Mitchell and her team, including Dr. Joan Tino. So a number of very prominent researchers in both geriatric medicine and palliative medicine. And it came out in the New England Journal in October of 2009, so quite some time ago now. And it was a fascinating paper. It looked at this cascade study, cascade standing for choices, attitudes, and strategies for care of advanced dementia at the end of life. And it really is credited for recognizing advanced dementia as a terminal illness. And what they did was they followed 323 patients with advanced dementia in 22 skilled nursing facilities in Boston. And I specify that because majority of the patients came from most likely higher socioeconomic backgrounds. 90% of them were white. So it is a very specific population that they followed, and their median survival they found was 478 days, and this was comparable to the survival of terminal cancer patients. So most patients died in the study from pneumonia, as you can imagine, most likely aspiration pneumonias, febrile episodes, so infection, and then eating problems, which we all know are pretty common in dementia and particularly advanced dementia. So almost 50% of the patients in this study ended up dying within 6 months of onset of an infection or a pneumonia or eating problems. And so again, this kind of solidified dementia as a terminal illness. Okay. So other important findings from the study that they looked at were that a number of patients had significant symptoms at the end of life as well. So in their advanced dementia population, there were a number of patients who suffered from shortness of breath or feeling air hunger, that's the dyspnea, pain and agitation in almost half of their patients. And these were uncontrolled or untreated symptoms at the end of life. And I'll touch on that a little later. Many patients were hospitalized as well in the last 3 months of life. So patients who were hospitalized most likely were not receiving hospice or comfort-focused care. And so they were still receiving a lot of aggressive treatment at the end of life is what that sort of translated into. However, the study found that if if the patient's surrogate decision maker, which I'll be referring to in the presentation as proxy, if the patient's proxy perceived that the patient had 6 months or less prognosis, so a quote terminal diagnosis, and understood the probable medical complications that came with that, the patient was far less likely to receive what they termed burdensome interventions in the last 3 months of life. So that includes hospitalizations, that includes invasive or uncomfortable treatments or therapies. And again, what this study kind of solidified was the recognition that advanced dementia is a terminal condition. And what they found was, or what they felt was from the study, that if patients or if their proxies could appreciate that advanced dementia was a terminal condition that came with a shortened prognosis, this could potentially lead to better anticipatory guidance from clinicians, from medical providers, from us, and conversations that could result in maybe more goal-aligned or value-aligned care for these patients. Okay, so hopefully I've convinced you that advanced dementia is in fact a terminal condition, and it represents really that final stage of dementia. So it goes without saying, dementia is progressive. It gets worse over time and usually reaches the final stage in about 3 to 6 years following diagnosis. So patients get diagnosed with dementia, and then within 3 to 6 years, reach advanced dementia on average. So what does it look like? So most of us have probably seen patients with advanced dementia, and it's pretty profound. So you can have severe memory deficits, such as inability to even recognize your own family member. You interact less with the environment around you. You have eventual loss of speech, so reduction of speech to a few words, and then eventual loss of speech. And you're really dependent on those around you for 24-hour caregiving. So total functional dependence, bowel and bladder incontinence, and patients are no longer able to walk independently or get around independently. They need help moving around. And it comes with medical complications, not surprisingly. So if you are so profoundly limited in your functional mobility and overall function and ability to make your needs known and interact with the world around you, it can be pretty hard to fight off infections. It can even be hard to take in enough nutrition. So the most common medical complications, unsurprisingly, are eating problems. So 90% of patients with advanced dementia will develop eating problems. That's the majority of patients with advanced dementia, which leads to complications such as aspiration pneumonia, which is a large part of the terminal course of this illness. Then infections. So almost half of patients with advanced dementia also have infections, and these can be harder to treat in the setting of a weakened immune system, in the setting of patients who may have trouble even taking oral medications. So patients with advanced dementia commonly die from these complications, which are caused by the disease itself. So in a number of resources, including several released by Dr. Susan Mitchell, she made this comparison that I thought might be helpful, definitely for us as clinicians to keep in mind, because I think a lot of us may not, myself included actually, may not always be able to equate advanced dementia with the really serious, significant illness that it is. So she suggested that it might be helpful to think of advanced dementia patients like patients with widespread advanced cancer, who are more prone to infections, which can be life-ending complications due to overall weakened defenses. So it's the underlying illness that leads to complications and death. So this comparison to widely metastatic cancer actually really shifted my perspective. Okay. I'm going to touch on medications in advanced dementia. It is one of our 4 M's. I suspect that others in this series are going to get into a little bit more detail about the medications and when to consider starting them. A lot of times we forget to stop them, or we think about stopping them, but it's really in the setting of advanced dementia. And so in general, there's actually very limited evidence to support the use of cholinesterase inhibitors like donepezil, rivastigmine, galantamine, or the NMDA receptor antagonist memantine in the setting of advanced dementia. So you probably shouldn't be started on them in the setting of advanced dementia. The question is, if you're already on them, because they might have been started when your dementia was mild to moderate, when do you consider tapering them or stopping them? And so, again, these anti-dementia and antipsychotic medications are no longer thought to be contributing in a positive manner or at all in the setting of advanced dementia. They really work kind of on the front end to slow down the progression of dementia. So closer to end of life in advanced dementia, it's probably more side effects that you need to worry about, which is why it's a good idea to consider tapering them or stopping them. And most of them will probably require tapers, so it's good to work with a pharmacist to talk about how to safely taper these medications so there's no withdrawal. Withdrawal symptoms could show up anywhere between even 2 to 6 weeks. So again, it's helpful to do this in conjunction with a pharmacist or with someone who has experience discontinuing these agents. And there's not really any great guidance or evidence. It's a little bit of hand waving, but we know that it could be important to taper them. Medications for other chronic issues, such as statins, lipid-lowering agents, calcium supplements, other types of supplements that are no longer providing benefits should also be discontinued. And part of the reason for that is because of polypharmacy and increased pill burden. And if you've ever taken a lot of medications or vitamins or supplements yourself, you might recognize that your feelings of hunger might be decreased, or you might have a little bit more stomach upset or nausea in the setting of a lot of medications on an empty stomach or with a lot of water. And so it's always a good idea to see if we can reduce the pill burden in our patients, and hopefully, because eating problems also take root in advanced dementia, improve some appetite, and we could even, hopefully have people continue to have relatively good oral intake of food as opposed to medications closer to the end of life. Okay. In order to make sure that patients or their proxies don't feel like you're taking something away, it is important to kind of introduce some of these ideas gently, sensitively, and thoughtfully. So we'll talk about that as well. Okay. So this is my husband and my oldest son with my husband's grandfather. This is when my son was, he was less than 1 year old then. And then my husband's grandfather developed Alzheimer's, and it was probably also mixed in with some strokes. And so he ended up in a facility, a long-term care facility. He's a veteran, and he was in the Air Force. So his flying buddy was actually Chuck Yeager. So here's my older son again about 6 years later. My husband's grandfather ended up on hospice, and so he's having a visit with him in hospice. So dementia and advanced dementia affect so many of us. Okay, so that cues me to introduce the kind of middle part of this talk. So that was the medical part. A large part of my talk, like I mentioned, is how do we talk to families and or decision makers, our proxies, about some of these more sensitive issues, because language matters, and it can kind of make or break whether or not families feel supported and comfortable in their decision making. Okay. So I had been a geriatrician for about probably 8 years, and my grandmother actually was diagnosed with dementia, likely Alzheimer's, about 5 years after I had become a geriatrician. And I'm relatively close to my mom, who's her caregiver. We talk often. And 3 years after she was diagnosed, I found out that no one had talked to my mom about the progression of dementia. And I think it came up when she was telling me about a friend's parent who ended up in a skilled nursing facility, and she had advanced dementia. My mom's friend's mom was no longer able to talk or remember family members, and she was struggling to eat. And my mom asked me, like, why do you think that is? That's so crazy. It's so weird. It just happened. And my friend doesn't understand why. And I told my mom, like, well, because she has dementia and she's in the end stages of dementia. And again, keep in mind, I had been a geriatrician for about 8 years now. And my mom said to me, oh my goodness, is that what happens to you in dementia? So I myself had not been very good at even explaining or talking to my own family about the progression of dementia, despite my grandmother having been diagnosed a couple years earlier. So her dementia progressed very slowly, but it just goes to show that it's really quite surprising how little we talk about these things. So if we don't think about talking to family members about this, if we don't think about talking to proxies or even patients about this, it might not come up, and no one might ever bring it up. So that was kind of eye-opening to me. So it brought up the idea for me of when or how do you bring up the idea of dementia as a terminal illness or a terminal condition, right? Because when you have a diagnosis of something like cancer, we all kind of know what the big C, what that could mean. And a lot of times that's associated immediately with, oh my gosh, I might die from this. But I think dementia, because it's oftentimes a lot more slowly progressive, it doesn't quite bring up that same emotional, shocking toll right up front. But I think, at some point, it's helpful to bring up the idea that it's progressive and that it could be a terminal condition for the patient who has dementia if they don't have other comorbidities. So how do you discuss dementia as a terminal illness? How do you discuss complications like eating problems and infections that could be life-ending? So I would argue that we need effective language and communication tools in order to have conversations about potentially scary or stressful topics to successfully learn about patients and their proxies, values, and goals, because our goal in palliative care, just like our goal in geriatric medicine, just like our goal in any medicine that we practice, is really to provide our patients and families with value-aligned or goal-aligned treatment and care, right? And it's a process. It doesn't happen overnight oftentimes, and it might take several conversations because these are sensitive topics. So that brings me to the matters most part of this talk. How do you get there? Okay, so most of us have probably heard of primary palliative care. It's the idea that there won't be enough palliative medicine clinicians to go around. Our population is aging rapidly. A number of us will have multiple comorbidities and chronic illnesses as we age. So all of us will need palliative care skills, primary palliative care skills, the ability to talk about these things and communicate effectively to get at goals and values so that we can provide that goals and values aligned care. You might have heard it referred to as serious illness communication. And one of the emerging trends in geriatric medicine is patient priorities care, which aligns with matters most in geriatric medicine. And patient priorities care seeks to get at values and goals a little bit more upstream. So prior to, in the setting of serious illness, already talking about goals and values and making sure that we have these things documented and that the care that we're providing even further upstream is aligned with our patients' values and goals. So no matter what you call it, it all involves compassion, good communication skills and tools, which we're going to go over today. And then just a lot of patience and grace, right? Especially in the setting of dementia and advanced dementia, patience and grace with our patients, with their loved ones who are struggling to make challenging decisions in stressful situations, and then with ourselves, because even the best of us think we know how to communicate well and employ all of these tools and skills. And you can still step in it sometimes. So part of what I'm hoping to impart is, we have some great communication tools and skills to get at goals and values. And one size does not fit all. So your patients best. You're probably already doing so much of this, and you all probably have foundational, fantastic communication skills. Otherwise, you wouldn't be in the fields that you're in. And you probably all have just a natural, wonderful way of communicating with your patients and their families. And we all can benefit from kind of some help sometimes, I think, especially in the setting of high emotion or stress when we're having some of these conversations. And so I oftentimes fall back on or rely on some of the language that I practiced or used in palliative care over the years to have these conversations, to make sure that there's some muscle memory in there where even in the face of a stressful or high emotion situation, I can still support my patients and their proxies in an effective and meaningful way and compassionate way. Okay. So again, some of the challenges with dementia in particular is I can have a long course. So the prognosis can be drawn out over years versus months. So sometimes when you think of other terminal illnesses like cancer, it can be shorter, it can be months. And you're not the same person, right? So patients' personalities might change, their memories are affected. So it's an illness unlike any other. So I think it's important to think about where in the disease trajectory the patient is compared to where the understanding of the patient or their proxy is. And what we call this in palliative care is prognostic discordance. And part of why this is important is because it speaks to a little bit of where you're starting from and maybe the readiness to engage in some of these conversations. Okay. Again, some of you might be primary care providers who have built up uniquely wonderful relationships with your patients over many years and potentially many decades, with your patients, with their proxies. So you might have a lot of rapport to draw on, and you might already have so much of the foundational knowledge of where this patient and family member are coming from as far as values, as far as goals overall. So these conversations might be easier. And it might be easier to what we say, like making a rapport or withdrawal. So if you've built up enough rapport, you can oftentimes make a withdrawal. And what we mean by that is you can oftentimes have these more challenging conversations a bit more comfortably, and you've already had some trust built up. So it might be easier than having to try to gain or establish trust with a patient or family that you're just meeting. Because again, a lot of these conversations, there's a lot of medical misinformation out there nowadays, right? You don't know where people are getting their information sometimes. You don't know necessarily what their lived experience has been, or who's informing them or what's informing them. And so there could already be some medical mistrust that you then have to work through. Okay. Other timing issues. So sometimes hospitalizations or paroxysmal events might come up. And that might actually present an opportunity to open the door to conversations. So if somebody gets sick with a pneumonia in the setting of their dementia and then comes back to your clinic and is perhaps a little bit more debilitated and their family notices that and wants to talk about it, that might open the door to talking about what issues might come up in advanced dementia and how to prepare for them. So I'm going to go over some what we call palliative care skills, preparing for meetings. And when I talk about palliative care skills, I want to clarify that I'm not talking about necessarily comfort-focused care, right? Because sometimes a lot of times, actually, I still encounter colleagues in Harborview too who know what I do, but then consider palliative care to be the equivalent of comfort-focused care or end-of-life care. And what I mean by palliative care, I'm speaking more to the primary palliative care skills. And as a field, we've evolved to really focus on communication and language. And so when I'm talking about palliative care, I'm talking about those communication skills that I hope will be valuable in having some of these conversations. Okay, so oftentimes the first thing we do as palliative care providers and geriatricians when we're thinking about having some of these conversations is to prepare, right? And so like I mentioned, this might be a patient that you have a long-standing relationship with, or it might be a new patient. It's going to be different if it's a new patient versus somebody that you know quite well. And I like to think about, I like to take some time out before I actually see the patient to think about what am I hoping to accomplish during this visit. So that could be, I could have some short-term goals, I could have some medium-term goals, and I could have some long-term goals, because like I mentioned, you might not be able to accomplish everything that you want to in one visit. And in fact, your visit might just be setting up for another visit, making sure that you know who the family wants to have, if you're going to have a serious illness talk or disclose the idea that advanced dementia is a terminal illness and what can come with that. You might want to have, or the proxy or patient might want to have certain family members with them at that meeting to hear what you have to say and then to have their questions answered. So you want to make sure that you have all the pieces and tools that you need and the people there, the important people there. We all do chart review. How advanced exactly is the patient's dementia? Are you in a place where this represents more anticipatory guidance because their dementia is moderate? Or are you kind of in the thick of it where now you're really seeing the effects of advanced dementia? Are there cultural concerns? And is an in-person interpreter needed? Is this a telehealth visit? Because we have a lot of those nowadays. So are you meeting a patient or family member by phone or by video conference? So we think about all of those things. And then to go on with our palliative care framework or approach, the way I often think about meetings is we always introduce ourselves first, have family and patients introduce themselves back. If this is somebody that you know, you get to greet them and hear how they've been doing. But definitely if this is a new patient or family that you're meeting for the first time, it's really helpful to get names and how everyone's related. I find that really helpful, especially for future meetings. And then we open with our agenda oftentimes. So here on out, everything in blue is language that I have either collected from Susan Mitchell's book on advanced dementia frameworks and talking to families, or that I've modified or that I've come up with myself in order to just give some basic language approaches to introducing some of these topics and ideas. This is by no means something that you have to use. I am giving some examples. I think we all have our own style. But if any of you have taken Vital Talk, which is a palliative care, serious illness communication course, what they often do is they focus on drills, language drills. So the idea is if you practice saying certain things, it'll come to you in the moments that you need it. So it's like I mentioned before, a little like muscle memory. So it's just like sports. If you practice kicking the soccer ball over and over, there's more likelihood that when you need to score that goal, you'll kick it accurately into the net. Same thing with the language, right? Because some of us aren't used to using certain language. And then because we've been trained and immersed in medicine and medical language so much, you might find yourself reaching for, lay language or more common terms, especially when using interpreters. That's particularly helpful to really keep in mind how to use straightforward, simple, and as few words as possible to convey your idea clearly. So language matters, practicing language matters. If we can practice it, there's a higher likelihood that we'll be able to repeat it when the time comes. And like I said, this is here, it's sort of a framework and it's providing some basic tools, but I fully expect anyone who's doing this work to put their own spin on it, to use language that they've heard that they felt was effective. Again, this is by no means the be all end all to talking to your patients. It's just some suggestions. So that's what the words in blue are and the language in blue. So that being said, introductions, greetings, and then I oftentimes just outright state the purpose of the meeting so that people know what I'm trying to cover, what I'm trying to get to, and it serves as a little bit of a guidepost, right? So today I'm hoping to talk about how we can provide the best medical care for your mother or your father. And I always try to personalize it. So I either will try to use the patient's name or I'll try to personalize it to the proxy, your wife, your husband, your partner. We want to make sure we understand what is most important to you as we think about his medical care moving forward. So I'm trying to just lay my cards out on the table. We check in a lot in palliative care, so it might give you some sense of where you're starting from, right? So just like the patient and family need a map, oftentimes we need a map to see where we're starting from and if we're starting from the same place. So I ask a lot of permission, and all throughout my conversations, I oftentimes ask a lot of permission for a number of reasons, but illness oftentimes robs people of any sense of control, and just asking permission seeds a little bit of control back to folks, where they can kind of decide what they want to talk about or where they want to steer things, and they can let you know if they're prepared to talk about those things or not. So is it okay if I start with a check-in? I'm rarely told no. I don't think I've ever been told no. How have things been going at home? Or if the patient is not at home, how have things been going at Skyline Terraces? How have things been going at Aegis? Try to use the name of the facility if possible. Again, I just try to really personalize things. And nursing homes and facilities can be a little triggering sometimes too, even. Because maybe they didn't want to put their loved one in a facility, but circumstances are such that they had to. So I try to use the name of the home. It's just a little bit more personal. Are there any questions you have about your wife's care that you want to make sure we get to today? So I usually will parking lot questions, or if there's some easy to answer ones, I will answer them up front. Okay. So moving on, one of the first things I also like to do is assess understanding. And I really try my best not to make this sound like a quiz, and not to make it sound like I'm asking you to repeat what doctors have said. If you don't understand it, I'm trying to get a sense of what the proxy understands or appreciates about where they're at or where the disease is. And I try to keep things open-ended up front and then get into more details. So if the patient or proxy is relatively new to you, and you've maybe looked in the chart, a good place to start is to just get a sense of about how long ago was Mary diagnosed with her dementia. And sometimes people have trouble kind of giving you a specific answer. And so to let them know that I don't need like the exact date, I will often say, was it several months? Was it several years? And then people kind of get a sense that it just needs to be general. Since then, has anyone talked to you about what challenges patients and their families can face over time in the setting of dementia, or in the case of dementia? And then I ask a little bit of a guidepost question. Is it okay if we talk a little bit today about some things to think about and prepare for? So you're entering into a little bit of a serious conversation about a serious illness. So if the patient and proxy are already established and you know them, I think it can be a little easier, right? Because then you can ask, or you can start at a different point. As you know, your mom has had dementia for a long time and is now in the final stages of this condition. Over time, dementia affects not just the brain, but the whole body. In addition to serious memory problems, she now has trouble moving around without help. So again, I'm really trying to avoid medical jargon, but also sort of medical jargon adjacent language that we sometimes don't think of as medical jargon. So I know for a while when I was on the wards, I would hear residents talking about goals of care or code status to their patients and families. And those are our terms. And even though, goals of care, none of that is quote medical jargon, it's still very adjacent to our medical jargon. And so if you are a layperson who's never heard of goals of care, been in the medical system enough to know what those things are, I think it can sometimes still be a little discombobulating. And so I really try to make clear and think about sort of what we think about a lot in palliative care is headlines. So are your words conveying meaning to patients and their families? If the sentence you just said were to be a headline, does it convey enough meaning does not just convey information, but also the meaning behind that information. Okay. So that's what a lot of these statements are trying to do, is really focus in on information giving, but also the meaning behind that information. So some language around advanced dementia as a terminal illness, because again, this can be a little tricky if nobody's talked about dementia in those terms before. And it can be scary, right? Because terminal illness can sometimes be a very frightening term. Anytime you talk about death or dying, that can be uncomfortable. Just some things to keep in mind. Again, just offering up some language that you might be able to use if you don't or haven't already developed language that you like using yourself. Some problems are very common in advanced dementia. Almost all people with advanced dementia develop problems eating. Infections are also very common. People with advanced dementia often die from these problems. Unfortunately, at this time, we don't have any treatments or medicines that can reverse or stop dementia or these complications. And then, as mentioned earlier, Dr. Mitchell and her team suggest that it might be helpful to offer the comparison of advanced dementia being similar to widespread advanced cancer, for which we also have no cure yet. And in the same way that cancer can weaken the body and its defenses, advanced dementia can also make it harder to fight infections or have the strength or appetite to eat like a person would if they were healthy. Okay, hopefully many of you have heard of the values triad. It's an idea in palliative medicine that we use a lot to try to suss out, especially if folks are having a little bit of a harder time prioritizing particular values or goals. It can give us a framework for trying to triangulate where people are. And it's the values triad made up of 3 values that we oftentimes can offer up and see which one people feel most aligned with. So the 3 values are comfort, being as comfortable as possible, longevity, living as long as possible, and independence, really prioritizing function and the ability to do things on your own for as long as possible and remain independent. So the ones that I think we'll talk about most in the setting of advanced dementia, probably going to be comfort and longevity. But there's this third instance. So if you're talking about comfort, it helps us plan the best treatment for your wife. When we know what matters most to you, we can match her medical care to your goals and values. And for some people and their families, being comfortable and having any symptoms like pain or trouble breathing treated very aggressively is really the most important thing, being comfortable. Even if this means not providing some other more uncomfortable medical treatments that could help her live longer. So comfort as a priority. If the main goal is to live as long as possible, the treatments we use might require procedures that cause discomfort. So longevity as a priority, it's a balance, right? So balancing being comfortable and living longer means thinking about the trade-offs in each situation. It might help to think about whether a treatment would help to get her back to where she was before she had the hospitalization or before she had a certain setback. So really trying to balance that, being comfortable, but still getting certain treatments to maximize the quality and the good amount of time they have left. Kind of strikes me as being that almost like that third option of function and independence. Okay. So continuing some supportive language around difficult decision making, I think it's really important to be supportive as best we can, because these are hard decisions. They might not be decisions that we would have made for ourselves or for our own family members, but we're not the ones in that particular situation. And so I'm very mindful to try to always make supportive statements to my proxies who might be struggling with really challenging decisions, life or death decisions as they may be in palliative care. So making these decisions is not easy. This is a very loving decision you're making for your dad. You are being an incredible advocate for him. And then I like to give permission, especially if there's family conflict or guilt, which there often is, because that too is support, right? It's okay to change your mind, because sometimes people do, right? Like you've had this lovely goals of care conversation and they might go home and sleep on it. And the next day they come back and will tell you, or maybe a couple days later, they might come back and say like, I slept on it and like, this doesn't feel right to me. I'm so sorry that I agreed to, X, Y, or Z. And it's okay to change your mind. These are really hard decisions sometimes, especially if you feel like you're making a life or death decision for a parent or for a spouse or a partner. It's okay to think about what decision will keep your family together, or what decision might result in the least amount of regret. I've told people that because sometimes that's the crux of the struggle. These are not easy decisions. We don't want our family members to be living with regret over their decisions, that erodes trust in us, in the medical system, and racks them with guilt and potentially settles them with guilt for the rest of their lives. So these are hard decisions. I can see how hard you're trying to balance what your mom would want in this situation with what your brother or sister wants for them. Okay. So some hot button topics in advanced dementia. As I mentioned before, eating problems, very common, 90% of folks. Treating infections, to use antibiotics or not, and hospitalization, to hospitalize or not, timing, when to refer to palliative care, and then when to refer to hospice.
Annie, we have a question that might be helpful right here, and that is to identify the difference between palliative care, end-of-life care, and comfort care.
Oh, wonderful. Okay, yeah. So palliative care grew up out of the hospice movement, right? So I think it's safe to say, all started back in England with Dame Cicely Saunders, and she was recognizing that we had gotten very good at diagnosing and treating disease, but we had kind of lapsed in our ability to prognosticate and then be able to treat people at the end of life. And the Institute of Medicine report that came out a while back also recognized that we are still to this day really struggling to take care of people at the end of life, to control their symptoms, manage their symptoms. But we're very, very good, and medical education and residencies have trained us all to be incredibly good at diagnosing and treating disease. And particularly, I think in the US, death is scary, stressful, and actually a hot button topic in and of itself, right? We're a very life promoting society and culture. So palliative care grew up out of the hospice movement, where we realized that we were no longer educating people well in how to take care of folks at the end of life, how to recognize prognosis, or how to prognosticate. And so we weren't doing it well. So palliative care sought to train up clinicians to get back to being able to prognosticate, to recognize terminal illness, and then to be able to treat the symptoms and challenges that came along with terminal illness. However, palliative care as a specialty is actually relatively new. And so I feel like we've continued to evolve from that, even just 10 years ago, when a lot of what we were doing as palliative care clinicians is more end-of-life care, maybe more comfort care, more goals of care in the setting of terminal illness. I think what we've evolved to now is very much communication, and a specialty where we do all those things. And we also try to intervene more upstream, and not just intervene upstream, but really promote the values of good communication over the course of medical treatment, promote the good communication throughout healthcare, right? Because now what we're recognizing is that our wonderful medical system and our medical training has maybe trained the ability to speak to patients and families in a way that they can understand us and understand what our treatments are and understand what the trajectories of their illness will be in the setting of different treatments. That's kind of something we've lost now because medical treatments and disease are becoming so complex. We have specialties upon specialties upon specialties. So we need palliative medicine and good communication skills to kind of help translate now and help bridge that gap between what we can do and the outcomes of certain treatments with what matters most in the goals and values of patients and their families. And so palliative care seeks to bridge that. So it's not just end of life care, right? Because that can include sometimes patients and families saying, I want to prioritize, my being independent as long as possible. Actually, I want to make sure that I live as long as possible, but my quality of life while I'm living as long as possible is good. And I want to pursue that curative treatment, even though you're telling me that there's such a small chance. And so we're really trying to kind of bridge that communication gap so that we are providing the care that people want and need. So I would say that's how I see palliative care now, is it's really the communication tools and skills to get to that values-based goals, concordant care. Comfort-focused care, again, and hospice are under the umbrella of palliative care, but we've really kind of moved away from just being the end-of-life symptom management folks. It's one of the things that we do, but again, really focusing on bridging that gap in communication for patients and families and our specialists and healthcare system. Hopefully that was helpful. Okay, so I'm going to move on to eating problems. And I think we're getting through this, so bear with me here. Again, very common. And when they start, it often signals a much shorter prognosis. So think about, from the time of diagnosis, those years down to now, weeks, days, when eating problems start, probably months to weeks, on the order of months to weeks. So shorter prognosis. Dementia is still a little unpredictable though, so always take the prognosis with a grain of salt. We're very bad at prognosticating still, especially in the setting of dementia. So what's the etiology behind the eating problems? Well, the brain's control of muscles and nerves involved in chewing and swallowing, which is actually quite complicated, is lost. Patients, you oftentimes might see they might chew, and then you come back 15 minutes later and they're still either chewing or there's a wad of food that they forgot to swallow, which puts them at high risk of aspiration. And then patients might lose the ability to feed themselves. Okay. So workup, like anything else, you still want to look for any relatively easy fixes, like if there's dental issues or pain that can be adjusted, maybe the food can be softened and the texture can be changed. And new infections like a UTI can oftentimes kill appetite. And then you can always be on the lookout for a new stroke as well, depending on what the goals are of care and treatment. And then, there's some simple fixes, like I mentioned, that can really continue to allow people to enjoy food and take in enough food to prevent weight loss for some time. So offering favorite foods, offering finger foods, offering small portions, like snacking or grazing throughout the day. And like I mentioned before, changing the food texture. And one that I think is underrated but really effective is just maintaining that normal social situation of eating with other people and having those around you talking and eating. Patients tend to want to eat when others are eating with them. Disadvantages of hand feeding, it can take a long time and intake may be very varied, but it's a very comfort-focused approach when you hand feed someone, as opposed to putting in a tube, either a nasogastric feeding tube or a percutaneous gastrostomy tube, PEG tubes. There's some advantages to that. It allows for ease of administration and a consistent amount of food and fluid, and you can give medications through it, but there's some clear disadvantages as well. So, does tube feeding prevent aspiration? No, right? Because the problem is that the swallowing function is affected, the muscles are weakened. Tube feeding does not magically improve dysphagia or reduce the risk of aspiration. It just allows for, like I said, that consistent amount of administration of nutrition. Does tube feeding help someone with advanced dementia live longer? So studies have been done, and the answer is no. So tube-fed patients with advanced dementia often continue to lose weight. As many of you know, if you have had tube feeding in your patient population, it often comes with diarrhea, unfortunately, and loose stools. And then patients sometimes need to be restrained or given sedating medications to prevent them from pulling the tube. And they no longer get that kind of comfort and quality of like being able to taste the food and the social interactions during mealtime. So how do we talk about it? Because like I said, it's one of those hot button issues. You might hear folks worry that their loved one might starve to death. Because eating is quite a love language, right? And eating is essential to life. So here's some language around eating problems. Eating problems are expected in the end stage of dementia. When eating problems start, we know that the end of life is getting closer. This is a natural part of the process of any terminal illness, including advanced dementia. From all of the medical evidence and personal experiences we have seen, even when people are eating and drinking very little, it does not appear that they sense hunger or thirst. They don't seem to be hungry or thirsty. They seem to still be quite comfortable. Eating less is something we expect in advanced dementia. It's a natural part of the disease process. The dementia causes the body to slowly shut down. Those of you who might care for folks from different cultural backgrounds or even different value backgrounds, eating can be, like I said, just a really controversial topic or something that just brings up really strong emotions. I come from Hawaii where, that's how we show our love is we cook large meals and we feed each other. And the way that we show love back too is we eat people's food that's been made specially for us. It shows that we appreciate the love. So food equals love in many cultures. You have not failed if you can't convince a proxy not to put a feeding tube in someone with advanced dementia. I think there's a lot of pressure on us as clinicians, especially in the world of geriatrics, to never put in a feeding tube in someone with advanced dementia. But if you have if you have a surgical team or a gastroenterologist who's willing to put in the feeding tube, it's not necessarily on you to block the path of someone, of a proxy who's determined or who feels very pressured from either family or cultural reasons or their own community to not allow the doctors to kill their loved one or to make sure that they get that feeding tube. And then some people are vitalists, right? And so the feeding tube can be almost more symbolic than anything too. So I think it's important to give ourselves grace to know that we have not failed as clinicians if we're not able to convince people that their loved one does not need a feeding tube. But for the reasons I mentioned, again, it doesn't necessarily confer any benefit. Okay. Treating infections. So most patients with advanced dementia will get infections. Often that signals the end of life is near. Pneumonia, particularly aspiration pneumonia, occurs in about 40 to 50% of patients, as I mentioned. And UTIs are also very common, so urinary tract infections. And then patients treated with antibiotics may live a few months longer. The trade-off being possible side effects or discomfort. They might need to be hospitalized. They might need IV antibiotics for effect. And those can come with side effects. So language around treating infections. And, not treating infections is mainly for folks who really, really want to prioritize comfort. So if you have people who really are trying to balance comfort and quality of life, that's when you really need kind of the, to balance comfort, quality of life with keeping folks around for as long as possible in a state that is reasonable or aligns with their values. That's when you want to try to balance and have kind of discussions around whether or not trained infection is aligned with the goals that they've outlined. So in the interest of time, you can kind of read. My language is kind of similar for all of these, including hospitalization. So planning ahead for acute illness. Acute issues will come up in the setting of advanced dementia. Folks with advanced dementia might still have a heart attack or stroke or GI bleed. Or an infection, which is common. So the advantages to hospitalization is that you get access to a higher level of treatment, including the intensive care unit, surgery, procedures, IV antibiotics, which can also be given at skilled nursing facilities. So some of the care can be provided in different settings, but the higher levels of care will be provided in the hospital. The disadvantages, as many of us are already aware, is that hospitalization can actually be quite traumatic and frightening to folks with advanced dementia or with even moderate dementia. It's a new environment, can lead to delirium and agitation, and then restraint. So it comes with a whole host of potential complications, including risk of more infection, bed sores, and, as I mentioned, delirium. Okay. So there's just a little language around talking about hospitalization and referring to palliative care. So we talked a little bit about the difference between palliative care versus comfort-focused care versus hospice. So palliative care, like I mentioned, is a specialty that really seeks to align goals with treatment. But it also does a number of other things, including helping to make difficult decisions and managing challenging symptoms at the end of life. And one of our specialties nowadays is actually also managing challenging family dynamics in the setting of making some of these more difficult decisions. So these are things I refer to as kind of secondary or tertiary palliative care skills. So maybe more specialist skills. It might be when you might want to reach out to a palliative medicine clinician, and then some help with cultural considerations, because sometimes we, as palliative medicine providers, might have access to more resources like cultural mediators and have more time to also recruit in-person interpreters. And so, and just have more time in general to dedicate to these conversations. So how do you introduce palliative care? One of the ways I do it is just by saying what we do. Palliative care is a medical specialty that provides information, emotional and spiritual support as you and your family work to think about what's most important moving forward. Specialists can help you understand the prognosis and treatment options, and the team can help you with difficult decisions if you are undecided or if there are disagreements within your family. And then referring to hospice. So I think of hospice as really a philosophy that aligns with pure comfort focused care. So really the goal of hospice is to provide the best quality of life possible free of symptoms, and really again, focusing on comfort, quality of life, dignity. So hospice provides care to patients who have a terminal illness, that means 6 months or less prognosis, oftentimes certified by 2 separate physicians, and who are no longer receiving curative treatments. All care is focused on achieving the best patient comfort and helping the patient to live as well as possible with the time remaining. And here's some language around referring to hospice in that similar vein. And just as a quick aside, I do want to touch on the article that came out in the New Yorker recently. Hopefully you've seen it or read it. It's actually quite long to get through, and it's actually like a pretty tough read. It's horrifying because it really takes what hospice was meant to achieve, and I think through kind of our greed and capitalism, it's become something completely different, where patients were not being served at all in some of these hospices that they highlighted in the article. But it really paints hospices in general kind of in a really bad picture, and vulnerable to being taken advantage of, particularly patients and their families vulnerable to being taken advantage of. So it's worth the read so that you know what people might be thinking about hospice when you bring it up, and how it could be actually quite triggering. So it's important for us to try to have good hospice resources for our patients and their families, and vet hospices that we can maybe hopefully guide our patients in the right direction towards good quality hospices that don't have the same issues that the hospices in that article do. Okay. So there are a number of benefits to hospice. Most being this 24/7 availability by phone. Families have someone to call and talk to. They provide durable medical equipment and medications, all related to comfort and symptom control. And it's made up of an interprofessional team of nurses, social workers, spiritual care, occupational therapy, pharmacists, aides, and volunteers. And there's grief and bereavement services for up to a year following deaths. There's a number of wonderful services and advantages to enrolling in hospice. I think it's important to keep in mind and emphasize to families that what's not provided is the custodial care. So families and friends would have to provide that care or hire caregivers, or patients would have to receive that care in a facility, skilled nursing facility, long-term care facility, adult family home, some assisted living facilities, depending on their level of care. Okay, and then medications and treatments with the goal of life prolongation or recovery are not covered and not provided, right? Okay. So just to touch on the functional assessment staging tool for Alzheimer's disease, this is actually what hospices and Medicare use to determine if somebody with dementia is eligible for hospice. You can say that they have 6 months or less to live. However, you also need to meet these requirements. And this is the FAST tool. And you really need to be quite debilitated in order to qualify for hospice with dementia. So this is a rating scale, and you actually have to not skip any of the steps. So you have to have all of these things in order to get to 7C, and you have to be non-ambulatory. Plus one of the following in the last year. So not only do you have to have, you have to be pretty debilitated, incontinent, no longer walking, only speaking 1 or 2 or no words, but you also have to have had some complication of advanced dementia in the last year. So what does that mean? It means that patients really can't qualify for hospice services until they're severely debilitated with advanced dementia, so no longer walking, really not speaking anymore, which means that they're probably already encountering eating problems, weight loss, and infections. And then care needs will already be quite significant. So by the time you qualify for hospice services, you've already probably are accessing a number of significant resources and services for your loved one. Okay. So in the interest of time, I'm going to kind of go through these palliative care pearls quickly so I can get to some cases and some questions. And the palliative care communication pearls are a lot of the things that I mentioned throughout the talk. Really, I ask a lot of permission. Again, that allows some control back. It also acts as a little bit of a warning sign or guidepost that just allows people to know that you might be entering into a topic that's a little bit more challenging, and it gives them the ability to exit, to head towards the exit door, or not enter into that conversation if they're really not feeling emotionally or psychologically prepared to navigate something like that. We love the nurses acronym, and it's really just some responding to emotion tools like naming, understanding statements, respect statements, and then silence is really important, right? We usually only allow like 3 seconds of silence when really on average we should allow more like 7 seconds of silence. And if you count that out to yourself when you're sitting with a patient or family, it can feel like a really long time. And it's oftentimes when you're on the verge of breaking the silence and trying to say something because it's so uncomfortable that something profound comes out from the patient or family that changes the course of the conversation in an important way. So it's important to give people the space for that. Okay, doesn't work on everyone. Different strokes for different folks. Don't assume you understand vague statements. I've gotten into trouble for that because I assume that, you know, a vague statement that somebody has said means something completely different. So I've learned now it's important to clarify. Tell me more about that. I heard you say this. In my mind, that means this. And then another tool we like to use is the I wish, I wonder, I worry statements. I wish we had better treatments for advanced dementia. I wonder, what your mom would say if she were here with us, right? You hear us use these statements if you've joined us in palliative care consults. And then, can I share with you a worry that I have? Again, asking permission, but also kind of touching on, I might be worried about something. Can I share that with you? To enter into some of those harder conversations. But all of these strategies are really aiming to provide a psychologically safe space to engage in these potentially stressful or challenging conversations. And then the cultural considerations. So I work with a diverse range of families and patients at Harborview. And in some cultures, talking about a patient's future can actually bring about that future. So we have to use a lot of slightly more oblique language where instead of personalizing more and using the patient as an example or the patient's name, we talk about, for many people with advanced dementia, we see this. For some families caring for a family member with advanced dementia, we see this. And then you can always ask about examples from their own experience. Gee, has anybody in your community that you know of struggled with dementia? And then Ethnomed is just a wonderful, free, accessible resource talking about many different cultures and how they might think about death, dying, grief, bereavement, and could sometimes give a little bit of groundwork with the caveat that everybody's different. So I'm going to go through these cases kind of quickly because they're really just to give you a little bit of a chance to think about the presentation and what we've talked about and maybe access like 1 or 2 of those skills. So the first case is Mrs. S, and she's 87. She's a longtime patient. You've been treating her for 10 years, and she was diagnosed with dementia about 4 years ago, was doing well at her memory care facility and was walking around, going to activities like seated yoga and crafts, and has some bladder incontinence, some urinary incontinence, needs a little help with dressing and bathing and toileting. Unfortunately, she fell and was hospitalized with a hip fracture, had that surgically fixed, and went to a skilled nursing facility for some subacute rehab. And she was able to return to her memory care facility, but her daughter is bringing her in because she's concerned that her mom did not recover quite to her pre-hospitalization baseline, and now kind of stays in bed for half the day and doesn't really attend the same activities she used to, and is no longer able to feed herself. She's worried. And you had not previously discussed advanced dementia with her and her daughter, and are not sure what her daughter knows about the course of dementia, right? Because some people look things up and maybe have some understanding of the illness, and some people haven't looked things up. So what are you hoping to discuss with Mrs. S's daughter today, and topics you might want to touch on? So if you feel comfortable, you should feel free to like type in the chat what you might want to just touch on, or where you might want to start. And it could be like one word or a quick phrase. You have your fingers warmed up, chat box open. What might you want to talk about, knowing that advanced dementia may or may not have been brought up before? And while you're thinking of that, you can also think about, after you've kind of greeted Mrs. S and her daughter, where do you want to start? What do you want to say or ask, or what would you say and ask to open up this conversation or introduce your topic? Oh yeah, wonderful. I see some wonderful things coming in. Have you noticed any changes in your mother's memory? Yeah, so starting off just like open-ended, like what have you noticed? And yes, to try to get a better understanding of what she knows and expects. Yep, assessing her understanding of of dementia in general, or of her mom's dementia. Oh, I love it. Tell me more what you're worried about. How long ago did your mother return to her memory care facility? Oh, has she had any OT or speech therapy? So what has been tried? Yeah, and just asking her like, what have you heard about the advancement of dementia? Have you looked? Has anybody told you about that before? Have you looked it up? Oh, occupational therapy, OT, occupational therapy. I think I would ask something along the lines of wanting to know what the daughter's knowledge baseline is and informing from there. Yep. Wonderful. And also wanting to know what the daughter would like to get out of the appointment. Of course, yes, wonderful. And then what conversations have you had with your husband about dementia? Beautiful. So that is all fantastic. I love it. Okay. Oops, did I skip? Okay. So I'm gonna continue with the case a little. So you have a telehealth appointment. So you have a telehealth appointment with Mrs. S and her daughter. The memory care facility, this is the next appointment. Memory care facility Mrs. S lives in has helped set up a video conference. Her daughter Jane is concerned that the memory care staff report that Mrs. Smith no longer seems interested in food. Previously, she had enjoyed meals and has lost 4 pounds over the last month. And during your last visit, which is the one we just talked about several months ago, you made great progress introducing the idea of advanced dementia as a terminal illness, but did not get into details about eating problems, right? Because this is a process. You can't always get everything done at once. So you weren't able to get into details about eating problems, hospitalization, and infections. But Jane was able to kind of understand and appreciate that advanced dementia is terminal illness for her mom. Jane was teary when discussing advanced dementia when you visited last, but felt she needed time to talk to her 2 brothers, Mrs. S's sons, about what their mom might prioritize. So she's now bringing her mom back, and she's concerned about her eating problems and her weight loss at the memory care unit. Okay, so what might you want to attempt to cover today? And then what questions do you have for Jane since last visit? And think about how you want to approach today's visit. What are you going to ask or say in order to start today's discussion? So now you're moving the advanced dementia conversation along, but you're in a new place and perhaps a little bit more of a more challenging place, because now it's the issue of eating problems, and Jane is bringing her brothers into the conversation. Any thoughts on that? Okay, we're getting to the end, so I am going to skip ahead because you have these slides and you can do these exercises on your own. Just a little twist. So same case, except Jane and her mother are Somalian. So instead of being cared for in a memory care facility, Jane has been caring for her mom at home by herself. She's the primary caregiver, and she has older brothers who frequently check in and can watch Mrs. S if Jane needs to run out for groceries or errands. But Jane, again, does the majority of caregiving. And after your last visit, Jane and her brothers decided that they want to prioritize longevity for their mom, who worked hard to raise and support them when they were young. And Jane and her brothers are very concerned that Mrs. S is eating less, sleeping more, and losing weight. So now what? So again, same questions. And I think it's very important to think about like how you might want to approach that visit. What are you going to say or ask in order to start today's discussion? Anything you would do differently, giving the little bit of twist in that case. And I love seeing these comments. Yeah. So a bunch of new ones came in. I think these are fantastic. Have you ever, so talking about the food texture, have you ever thought about softer foods? Can you tell me what types of food she has been eating? Does patient have an advance directive? Does daughter know what the patient's wishes are? Oh, yep, great. Perhaps a Zoom meeting, inviting the siblings. Yep, if they're willing. To make sure that everyone's on the same page. I'd start to ask what she thinks her mom would want and explain eating issues. Yeah, these are great. These are all really wonderful. So in order to just give you guys some time for questions, here are the sources and citations that I drew from for this presentation, and particularly helpful, I think, is this dementia guide. It is free. It was developed by Susan Mitchell and her team via a grant, and it has a lot of the language that I used in today's talk. However, like I mentioned, her audience is oftentimes a bit more socioeconomically well-off, white, English-speaking, and college educated. And so I think, the language that I tried to present in the talk today hopefully is a bit more universal. That's my family. My grandmother got diagnosed with dementia, and there's my mom and my 2 kids. So thank you very much for listening. As I mentioned, I think dementia affects most of us, and we all have brushes with it sometime in our life and as caregivers. So yeah, hopefully some of this was helpful.
This was great, Dr. Hirano. I so appreciate it. And I think you can see all of the kudos in the chat. Do you have time for a couple of questions, or shall
Absolutely,
I?
absolutely. I'm sorry
Okay.
that took longer than I thought, but like I said, I think I kind of warned you in the beginning. I could talk about this all day. So
well, we're really glad you did. I really appreciate it. Linda Pike was wondering, she said in her experience treating, and this was back to when you were talking about treating infections, even though advanced dementia, the end of life was more peaceful with less side effects from the infection. And someone said they agree about treating the infection, but then Lisa brought up the fact that treating the infection can also delay death sometimes in a painful way, like their lungs kept filling up over and over, but the pulse was full treatment. Do you have any comments about that issue about treating infections and the sort of pros and cons, I guess?
Yeah, absolutely. Those are such great questions because they come up all the time, right? Like these are are hard topics to navigate sometimes, I think. So what I oftentimes do is sometimes family members can have strong opinions about whether or not they want antibiotics, because even if you're comfort focused care, it's hard to let go of what's been ingrained in us as just lay people in our society, right? That antibiotics help you. Antibiotics cure infection. So if I'm telling you that your mom has an infection, why would you tell me that antibiotics wouldn't help that? Wouldn't help even make her more comfortable. And so I think, I try to say up front, like, if I recommend it or not based on the goals and values that I know that the patient or family have already outlined for me. If I don't know them, I just kind of do a check and say, like, I understand that you want your mom to be as comfortable as possible. Can I recommend something in this situation? And I will give you my reasoning behind that. And so I start there. But like I said, if it's something that they're just really attached to, and you feel like maybe you're in the position where you might not be able to divorce someone from the idea that antibiotics are necessary, and you might feel like, oh, I feel like I'm almost treating this family member more than the patient. Sometimes you're going to be in that situation, right? And so what the tack I tend to take is, I don't say like, absolutely not, I'm not going to give them antibiotics because I'm the doctor. I will say something like, here's what I worry about if we go down the course of antibiotics. And I'll say, like, I worry that we might be prolonging a state of suffering for your mom that you've already told me might not be acceptable. And sometimes people have to go down that road a little before they see that too. So if I'm really kind of in a stuck place, I'll say, like, let's do this. Let's try it. And here's what I'm going to be looking for to inform me that maybe this isn't the right path to go down, and that maybe the side effects or your mom's symptoms might be overwhelming or might be overriding any benefit that the antibiotics are providing. So sometimes you have to walk down that path just a little. So that's one of the things that I do, one of the tools that I use. Because, right, this is not like a all or nothing, similar to what I said about the feeding tube. You haven't failed if, like, people make certain decisions that you're like, oh, choosing wisely told me that's not a good thing. Feeding tubes and advanced dementia. So you have to be willing to, like, walk with patients and families where they're at, even if it's a little down that path, but always make sure that it's like an informed walk, that you can say, like, let's look at these things though, and then, like, let's recalibrate if we're getting into something that that's not aligned with our goals.
I like that idea of walking with them. Mary Zeitner just asked, are there any freestanding hospice programs in the Seattle area, or are the choices in this area home or hospital?
Yeah, isn't that fascinating? Seattle has very few inpatient hospices. For a relatively decent sized city, we really don't have many inpatient hospices within the Seattle area. So what you'll see is, unfortunately, people being treated and placed in a long-term care facility or their home or a facility. Or if their symptoms are really out of control, sometimes we, as a Providence Hospice medical director, I used to have to send people back to the hospital for symptom control, and we would have to get control of their symptoms in the hospital. So the Evergreen, I think, has an inpatient facility, but it's usually, and I could be wrong, my information could be a little outdated. So if there's anybody from Evergreen who wants to put something in the chat to correct me, I know that if your symptoms were pretty out of control or advanced, like you could have that inpatient stay for a couple of days, but it's really not a long-term solution. It was meant for like a couple of days. And so that's kind of more the resources that we have in Seattle. If you're Medicaid, Bailey Boucher is essentially a hospice. They like to take patients with a prognosis of 3 months or less, though, because they found that some of the patients with 6 months or less prognosis were actually like living for years, and they're a limited resource. So they wanted to just have their resource be a bit more available for folks. So yeah, our resources for inpatient hospice in the Seattle area are actually really limited.
Mm. So Teresa Garner was saying that patients' physician should recommend hospice months before the end to help prepare the patient and family members of what's coming and help to come to terms. Palliative hospice care are so important for patient and family to understand the difference and how they work and when to go the next step. Any additional comments on that?
Yeah, we love talking about like trying to get folks to the type of care that's aligned with their goals and values upstream, right? So that they can take kind of full advantage of the resources available to them and that they deserve and that can help support them best. And as I mentioned, I think the one real challenge of hospice for advanced dementia is you have to be so darn debilitated before they take you that and you know, most hospices, unlike in the New Yorker article, most hospices, at least in the Seattle area that I've worked with, are very, very scared of being audited and accused of Medicare fraud. So they really do, for dementia, advanced dementia cases, like you really do need to no longer be walking and no longer able to say many words. They're pretty strict about that in the Seattle area. And so again, it's actually like really challenging to get our patients and their families to hospice in advanced dementia, which is unfortunately such a shame because the resources, that's immense support, right? Just having your medications, having a 24/7 number that you can call, the grief and bereavement resources, the medical equipment, all of those things. We want for our patients and their families to support them as best we can. But yeah, you have to be, like I said, really, really advanced before they'll take you.
Susan mentioned frequently we could admit patients to hospice due to weight loss, 10% in 6 months. That's
Oh,
about it.
wonderful. I think Susan is part of hospice. So yes, yeah, that weight loss criteria, that's really helpful. I think, you know, when I was medical director, it was still in the days where there used to be debility. And Wayne McCormick used to call it like the wastebasket diagnosis, terrible, but kind of, it's like, it was like the everything diagnosis, right? Debility. And so we used to be able to get a lot more people into hospice, even with advanced dementia. But then when they got rid of that debility diagnosis, like advanced dementia is really kind of the one that you have to use. And then you do have to follow the FAST scale. So yeah, you're right, Susan. Like I'm so glad that I think hospices really try to get folks in who would benefit appropriately from hospice, especially in advanced dementia, because I think hospice people recognize that it's really challenging to be a caregiver for someone with advanced dementia, and they know their services, the hospice services, are so valuable. So yeah, I'm so glad that they really take everything into account to try to get people in before they're like 7C or greater on the FAST scale.
Well, these are just great. There's a couple more questions, but I think they're just kind of sharing information with others. So I'm going to say thank you so much, Dr. Hirano. I just this is such an important topic, and you bring a very heartfelt approach to it, which we all appreciate a great deal. So thank you, and we'll see all of you next week.
Thank you.
Thanks.
Thank you for joining us.